Hi, I'm Dr. Aliabadi. If you struggle with irregular cycles, acne, facial hair, body hair, hair loss, or insulin resistance, you might be dealing with PCOS or polycystic ovarian syndrome. Having dedicated my life to helping women with PCOS, I understand the challenges in getting an accurate diagnosis and the right care. That's why I created Ovi, a science-backed alternative to prescription medications. Ovi is designed to help you take control of your health with clinically proven, validated ingredients in a simple, once-a-day solution. For too long, women with PCOS have had to choose between lifelong prescriptions or complicated supplement regimens. Ovi offers a better way to help manage your symptoms without the hassle. It's my mission to empower women facing PCOS and other hormonal issues by providing the information and support they need. Reclaim your health once and for all. Go to ovi.com. That's ovii.com and start today.
So today we are so lucky to have the founders of Midi Health. I was so excited about this podcast because we met about a year ago and I've been trying ever since then to get you on the podcast. So I'd just love to hear how y'all came together and a little bit about your background for our listeners.
Yeah. So we started Midi about 3 years ago, and it was really because of my experience trying to get access to hormones and get access to really educated hormonal assistance. You go to your doctor and you're not sleeping and you're having anxiety, and essentially what happens, they say, "Oh, go get a sleeping pill. You're having anxiety," and no one puts it all together and says, "Actually, this is all perimenopause." And it took me a really long time to get that care. And once I did, and I drove an hour and a half, and I went to a very fancy concierge person and paid them $1,500 to get this level of care. And 2 weeks later, my life changed, and everything in my life was better with the right medications. And what was really clear to me is that we needed to democratize access to this and to basically create a national company that would give everyone access to this level of care and make it covered by insurance. And so that was the basis of the company. And then Dr. Goldman was at UCSF and led something called the Survivorship Clinic there, which is focused on women who were at high risk of breast cancer or had breast cancer. And I had a lot of friends in this category who were suffering really terribly from having symptoms of menopause and perimenopause that was driven by the breast cancer treatments or driven by an oophorectomy or a hysterectomy, and they weren't getting the right care. So I called Mindy and I said, "We're starting this menopause clinic." And
she said to me, I think survivorship is an unmet need. And I was like, this is what I've been saying for years. And so timing was right that I could semi-jump ship from UCSF and join Joanna. And 3 years later, we're on this amazing journey.
So Dr. Goldman, can you just tell us a little bit about your background and everything that you're doing?
Yeah. So I'm a general OBGYN by training. And similar education was sort of my thing. So I ended up in academic medicine. And my dearest friend got breast cancer at a young age and passed away in a year and a half.
How old?
She was 42.
Ugh.
And I went on leave to help take care of her. And when I came back, I decided I wanted to kind of shift my career and learn more about breast cancer patients. And I ended up working in the breast care center side by side with oncologists and breast surgeons. What started happening was people would come up to me and say, "Hey, this person was thrown into menopause from chemotherapy. What do I do?" And this person's having bleeding on this breast cancer drug tamoxifen. What do I do? Or this person wants to figure out what to use for contraception. And this is in the 2000s. And I start researching what's in the literature and went, oh my gosh, there's like nothing out there. So fast forward now 20 years, I have helped develop a field that I sort of think of as bridging breast oncology and gynecology. So I've been lucky enough to work with the American College of OBGYN and writing their guidelines for practicing gynecologists nationally. And I work with the National Comprehensive Cancer Network. and I chair their menopause and sexual functioning survivorship panels to help give guidelines. And so I felt like I've been able to make an impact, but what I wanted to do was scale this care so that I could make more of a direct impact on patients. And so when Joanna found me and said, I think this is an unmet need, I felt like I've been saying this over and over again. What we're getting to do is really help survivorship patient cancer, both people who've had cancer, people at high risk nationally with insurance covered care. And no longer do people just need to hear, be thankful you're alive and just suffer with the consequences. We're helping them feel better.
And I mean, first of all, you're an angel. I'm looking at you, the light's shining on you. I'm like, this woman is like an
It's so
angel
true.
sitting right in front of me. Thank you for doing what you do. OBGYNs are always so busy doing their own thing. It's rare for someone to look at the big picture and start helping women in this subgroup of patients. I had breast cancer. And honestly, I will tell you, even when you go to your oncologist, they don't know what to tell you, right? The most you can get from your oncologist is a vaginal estrogen. And they approved that after a couple of years of suffering. Exactly. And so I would love, we've never actually done a podcast covering breast cancer and menopause symptoms. So I would love for you to teach us and our audience what they need to do. Like, start with, if you are at risk for breast cancer, meaning let's say your lifetime risk is 20% or more. What do you recommend for hormone replacement for these patients? What if their lifetime risk is 35% or more? What if they have a genetic mutation, let's say like CHEK2, that puts them at 50% or more? How do you treat these patients? And then let's shift to patients with breast cancer.
That's great. I love it when I get to talk about this. First of all, when it comes to people who either have a family history, and I'll put genetic mutations into that same group, they are told almost uniformly throughout this country by providers, don't use hormones because it's going to further increase your risk of breast cancer and you're already at risk. And that is really outdated information. First of all, the question to look at is, does hormone therapy even increase the risk of breast cancer? And a lot of what we know was based on this large women's health initiative, now published more than 20 years ago, which scared women because that study was stopped with the finding that hormones in one group of women who had gotten estrogen and a certain type of progesterone had a higher risk of breast cancer compared to the placebo group. And everyone in this country stopped their hormones. And for the past 20 years, anyone who's trained in medicine didn't get adequate training in menopause because they thought hormones cause breast cancer. So first of all, we use many different types of medications now. And the types of hormones that are most often prescribed are bioidentical forms of estrogen and bioidentical forms of progesterone, which means similar to what our own body produces. And there is evidence that those are more breast neutral. So we know from the Women's Health Initiative that the component of hormones that had breast risk was the progesterone component. So I'm trying to simplify.
No, don't. It's so good, the information you're sharing.
I understand it. So
No,
I understand.
please go into detail because there's so much misinformation about
Yeah.
this specific topic.
So in the Women's Health Initiative, they used a very specific type of what's called a progestogen, which was a synthetic form. What's used now are bioidentical forms of a progestogen that is called progesterone.
That's what I take at night.
Exactly.
Okay.
Progesterone is the same as what our own bodies produce after we ovulate every month. And there are more and more studies that say bioidentical forms of progesterone are safer and more breast neutral. So one question is, do the current formulations of hormones that we use now even increase breast cancer risk? And when you look at the studies, the risk is largely confined to studies that use synthetic progestins and not these bioidentical forms. So I'm not convinced that current formulations of hormones increase breast cancer. Then getting back to your other question is, What about people who are at higher risk? So they've got a family history or a genetic mutation. When you look at literature that has looked at, do hormones add on to a risk? The answer is no. The vast majority of studies say if there is a risk with hormones, it's an independent risk, which means all the things that people are being told of, you can't use hormones because you have a family history, just isn't true. Now, that doesn't mean they don't need to be followed closely. They should be doing lifestyle things that can help prevent breast cancer, like getting regular interval cardio for exercise, minimizing alcohol, maintaining normal body weight. They should be getting appropriate imaging. Depending on their age or when breast cancer was in the family, they should be getting nowadays 3D mammograms plus or minus an MRI, depending on how high their risk is. But that doesn't mean that they can't take hormones. And that's one thing that I would love for your listeners to hear. Don't be scared about that.
So I have a question.
Yeah.
When I have a patient, let's say with a lifetime risk of breast cancer of, I don't know, 48%, we do offer them either monitoring every 6 months with mammogram, ultrasound, and MRI, or obviously they have the option of having a double mastectomy, which is what I decided, which is a very personal decision. But we also do offer them, let's say, tamoxifen for 5 years to reduce that risk by 50% in, within a 10-year period. So my question to you is, if we are offering these patients an estrogen lowering medication to reduce their risk, wouldn't common sense say that someone at such a high risk with estrogen might be at a higher risk? As an example, when I have a patient who sits across from me and I'm telling her your lifetime risk is 50%, let me give you tamoxifen for 5 years. You lost your mom, your aunt, you don't have a genetic mutation, but 50% is a big number to swallow when it comes to breast cancer.
The relationship between hormones and breast cancer is very complex. And I take it back to the WHI, because in the WHI, there were actually two groups of patients studied: women who had a uterus and women who had had a hysterectomy. And for the women who had had a hysterectomy, they got estrogen only, because generally estrogen is the component of hormones that makes you feel better. It alleviates all the symptoms. That part of the study, they found a lower risk of getting breast cancer, and they followed those women out to current day. Wonderful article published in one of the premier medical journals, JAMA, in 2020, looked at 18-year follow-up at that point from the WHI, and they showed for the women who got estrogen only, statistically lower risk of getting breast cancer and statistically lower risk of dying of breast cancer. So that's what showed us that it was the progestogen component. Yet when you have breast cancer, we give you these anti-estrogen therapies. Tamoxifen has both estrogen, as you know, estrogenic
on the uterus, right?
Anti-estrogenic and estrogenic effects. The other class of drugs, the aromatase inhibitors, all shut down estrogen. But I tell that story to people to say it's very complex, because we know estrogen only prevents you from getting breast cancer and prevents you from dying of breast cancer. But when you have breast cancer, we modify the tumor environment by giving you these anti-estrogen
That doesn't make
therapies.
any sense to me.
It says, though, that it's a very complex topic, and you can't then just make that correlation that when you have breast cancer and we give you these hormonal therapies to modify that local tumor environment, right? So we're giving these just to modify the tumor environment,
anti-estrogen
to modify the tumor environment. Yet you are a healthy person that doesn't have breast cancer. The best evidence we have is that estrogen only will prevent you from getting breast cancer. So it says to me, though, it's not just, it's how all these hormones interact, right?
I want to ask, because I'm a little confused, and I know a lot of women listening are not doctors. So what you're saying, and I want to make sure that I'm clear, is that if you've had breast cancer, you want to be on anti-estrogen, because if it's a form of breast cancer
if it's a hormone receptor positive.
Okay. But if you are a healthy woman without a high lifetime risk of breast cancer, or a genetic mutation, estrogen will help you not get breast cancer.
Actually, maybe even if you do have the genetic mutation.
Thank you for saying.
Okay, good.
Yeah.
So
I also will clarify, when you have hormone positive breast cancer, I think there are a lot of people out there that think hormones caused me to get breast cancer. It just means that they're going to use these hormonal therapies, tamoxifen, the aromatase inhibitors, to modify the tumor environment. And once someone has a cancer and they're modifying that tumor environment, that is very different than someone taking HRT, healthy breast tissue, taking HRT for symptom relief or disease prevention. For many times we know
Many
that it's
heart
prevented. Yeah.
hospitals,
Yeah.
Let me tell you why I'm so traumatized personally, on a personal level. I had no family history of breast cancer, no genetic mutation. I was vegetarian for 7 years. I never smoked. I'd never done drugs. I rarely drink alcohol. I was in the best shape of my life. And my lifetime risk was 37.5% because I had atypical lobular hyperplasia at the time. So I did an excisional biopsy. I always calculate everyone's lifetime risk. And my lifetime risk was 37.5%. I had 3 little kids at the time, and it was a hard number for me to swallow. And they told me every 6 months you have to go to mammogram, ultrasound, and MRI. I don't know if you've ever done a breast MRI. It's not an easy procedure with the contrast, and you have to block 2 hours of your time. And I just couldn't see myself doing that every 6 months. It was just too much. So I wanted a double mastectomy. Doctors would not do it because of my risk factors were low. And so finally, I found a doctor who was willing to do it. They did my double mastectomy. And a week later, they told me I had breast cancer, invasive stage 1. I had tried tamoxifen. It was toxic to me when I took it. I couldn't sit. I couldn't move. My muscles were cramping. I was having hot flashes, vaginal dryness, night sweat. I had it all. So I stopped it and I opted for a double mastectomy. To this day, I don't regret it. And in the past 2 years, 3 patients with a prophylactic double mastectomy that ended up either having stage 1 breast cancer or a lot of atypia, a ton of atypia bilaterally. So,
which is what?
like precancerous abnormal cells in the breast tissue. My question to you is, you're saying someone like me who would have benefited possibly from being on tamoxifen would not have a higher increased chance of breast cancer had I taken hormones at that time?
We don't. So based on my review of the literature, I think that hormones does not add on to that risk, which is what people thought, that you're already at high risk and you add hormones and it's like putting water on, it's just going to increase that risk further. And we don't have good evidence that says that it does. Interestingly, one of the things we are doing now in some of these high risk patients, like people that do have breast atypia, is the hormone drug Duovy.
Yes.
So
Which is
Duovy,
what?
It's
yeah, so
amazing.
it's a fascinating drug. So Duovy combines estrogen, actually the same estrogen that was studied in the Women's Health Initiative. And instead of using a progesterone to protect the uterus from uterine cancer, so when people take hormones, as I said, estrogen makes you feel good, progesterone is used so that you protect against uterine cancer. This drug Duovy, instead of using a progesterone for uterine protection, they use a cousin drug to tamoxifen. Now, tamoxifen is in this class of drugs that are called selective estrogen receptor modulators. It acts like estrogen in some tissue and unlike estrogen in other tissue. So tamoxifen happens to not be good for the uterus. In women who take it after menopause, it increases uterine cancer risks. The drug in this Duovy, that's a cousin drug to tamoxifen, protects against uterine cancer. It's not available on its own in the United States. It is in some other countries, but in the United States, only in this drug Duovy. And there's preliminary studies that show Duovy is preventative for breast cancer, and it's being studied around the country in high-risk women, people who have atypical ductal hyperplasia, atypical lobular hyperplasia, even DCIS of the breast, to see
So
if it
what are all three of
treats.
those in
That's
layman's?
so those are abnormal cells in the breast that are precancerous.
Okay.
Yeah,
So
the
they all of those
potential.
things, yeah, they increase your risk of getting invasive breast cancer. And
That's amazing.
Duovy, there's some it's a FDA approved drug for treating menopausal symptoms. It's a type of hormone therapy and preventing bone loss, but it's being studied to prevent breast cancer. At Midi, we're seeing 11,000 people a week. Not all are high risk for breast cancer, but for the people that are, we counsel them. This is what literature currently shows. There's preliminary data that says it's preventative. Let's talk about whether you might be a good candidate for a drug like that.
Can we talk about your amazing company? And again, I mean, I'm just so impressed by both of you. How does it work? If I was going to go on Midi Health,
Essentially, the way that it works is you come to our website, you tell us what state you have and what insurance you have, and then you book a visit with us. It's an online visit. It's a 30-minute consultation where we talk to you about your family history of breast cancer. We understand where you are in your health journey and what symptoms you're experiencing, and we start certain medications or supplements, whatever is of interest to you. So your goal is to start a medication. Then you'll come back in a month and we'll say, how is it working? Do you want to go up? Do you want to go down? Do you want to try something else? And we basically iterate with you. I think we've prescribed over 500 different medications. So we're super important. We're not a pill mill. We are not selling you a medication. We are there to advise you on what are the right medications for you to try. And then honestly, one of the things that Mindy has set up that I'm probably most proud of is we have our complex care channel. So we have experts, doctors like Dr. Goldman on the back end who not only review the charts, but if you have a complicated case like you're talking about, an expert will review it and give consults and make sure that the care was really good. So sometimes we'll have 10 doctors weigh in on one patient. I mean, literally, you will have, an internal medicine person and a bone person and a cancer person all weigh in on one patient about what the right care is. So I think we're giving the best care in the world because we have this brain trust of brilliant people looking at the care and making sure that it's good.
So a couple things that I always talk about when I'm talking about Midi, that I'm a better physician since I joined Midi, and I was in practice for a long time.
And why do you think that is?
I'm a better physician because I'm much more holistic in my approach. So we have our medical leadership team, and together we have written protocols that give guidance to our clinicians for care. And we also go out to experts around the country to help us in creating those protocols. For example, our protocol about the use of hormones in people who have had blood clots or maybe at higher risk for blood clots. We found a expert at Northwestern. There aren't that many hematologists that know women's health well. She helped us with our protocols. We did the same for psychiatry. We do the same for bone health. So we have protocols that cover both women's health areas and primary care. And in the past, when I was in practice and someone came to me with hair thinning or weight gain, I was pretty quick to say some superficial things and say, go see your primary. And now I know evidence-based information to tell them. And that makes me feel like I'm a much better provider. I'm so much more holistic.
You are amazing. What about patients with blood clots, with history of blood clots?
Yeah.
Tell us.
The most common way that hormones are prescribed nowadays is with a non-oral form of estrogen. So usually a patch, sometimes gels. We know oral forms of estrogen can increase the risk of blood clots, but there are vast majority of evidence shows that transdermals, non-oral forms don't increase clot risks. So it depends on the situation, but there are many people, if they had an induced clot that had nothing to do with hormones, that it is perfectly safe to give them hormone therapy. We will evaluate patients and figure out, did they have a clotting disorder? Because there are some clotting disorders that we know it's likely safe, like one heterogeneous
Factor five,
factor five Leiden. There are others where there's a little less evidence. We know that national organizations are slow to make change. They're still telling people about data from the WHI 20 years ago. We are constantly looking at the literature, and we take the most up-to-date information and we guide our patients with that and then do shared decision making to help them come up with what's right for them.
What do you guys do for women with breast cancer? Yes.
So, first of all, we know breast cancer is not breast cancer. It's not breast cancer. So it's a compilation of a number of different disorders. So, for example, 2/3 of breast cancer is sensitive to hormones, but 1/3 is not. For that 1/3 that isn't sensitive to hormones, oftentimes when they're diagnosed, it's more serious because we don't have all these hormonal therapies like tamoxifen and the aromatase inhibitors to use. And so they get chemotherapy frequently. But if they don't recur after a number of years, typically by 5 years, we'll say you're cured from that cancer. Versus we know sometimes with hormone positive cancers, we can sometimes see even late recurrences 15, 20 years down the line. In people who have hormone negative cancer, there is not good evidence that says the use of hormones increases the risk of them getting another cancer. They're at higher risk because one of the risk factors for breast cancer is having previously had breast cancer. But hormones are not thought to further increase that risk. So when people have been free of disease for a period of time with hormone negative breast cancer, we will counsel them and we will offer hormones. We also realize that no one is seeing us in a vacuum, and they have other physicians that they see, their primary care, their GYN, and sometimes still their breast specialists. So we've also created letters that outline this is the thought process of what we've done. We will talk about what is recommended. So always with hormone positive disease, we recommend alternatives to hormones. Then we talk about what are the situations where we might offer the drug Duovi. And then we do shared decision making. And there are people who had hormone positive breast cancer years ago who are really suffering, and they say, I'm willing to accept the risk. And we tell them, here's what we know in the literature. We know that the current formulations of hormones that we use now are safer and more breast neutral. What's missing in the literature is studies in breast cancer survivors with the current formulations of hormones that we're using. That's a gap. If patients understand that gap and they've been doing well for long enough and they are willing to accept the unknowns, we will sometimes offer hormones. And then we give letters to their providers with references that they can look up that shows we're not doing some crazy stuff, that we've been very thoughtful about this. We've talked them through all of the options, and here's the references if you want to do a deep dive and understand what's known and what isn't known.
I was
And
recently.
I was going to say, sorry, if you follow your own patients on your platform, 10 years from now, you're going to have a wealth of knowledge and
Yeah, I mean,
information
all
on
of
these
these
Joanna
women.
women.
knows I want to start publishing. She knows I'm
That's
an
the
academic.
best part of this
No,
platform.
This is amazing.
Yeah.
And with Midi Health and all of these women that come on, do you find that they're searching for hormone replacement, or are you sort of needing to teach them because there's such a big lack of education?
They're hormone curious.
They're
That's the word we
hormone
use.
curious. I love that, being hormone curious.
They don't know if it's right for them, but they are interested. But I was going to say, recently I was at a party and a woman came up and she hugged me. She said, I'm a doctor. I had breast cancer 15 years ago, and I had the double mastectomy, and actually her partner was standing with her, and she said, and my life was falling apart, and I really was suffering, and I couldn't get my oncologist to prescribe the hormones to me. And I went to Midi and I had a conversation with the provider. They went and reviewed all the literature with me. I did choose to take the hormones, and it's changed my life. And she started crying when she was there at the party, and her husband hugged her, and he's like, it really did. It changed her life. What we feel really strongly about, and this is with regard to a lot of things, is that our job is to give you the options, not to be a gatekeeper, and then let you decide what choices you want to make.
I have a question. Going back again to breast cancer patients, you said non-hormonal options. Brain fog, lack of sleep, hot flashes, night sweats, vaginal dryness. Can you go over all the non-hormonal options for our listeners
Sure.
for the symptoms
So-
of menopause?
The way I like to describe it is if someone's a candidate for hormones, I like to think of hormone therapy as this broad treatment that affects many different symptoms. But if someone isn't a candidate for hormones, they're in the middle of treatment, they're on tamoxifen, they just finished their aromatase inhibitors. We need to target the individual symptoms that they have. So first, you mentioned vaginal dryness. There is good evidence that the use of vaginal hormones does not increase the likelihood of dying of breast cancer. Very, very good evidence. Just a large study published in January, a big systematic review of all the literature that showed no influence on dying of breast cancer. It's a little bit controversial with patients on aromatase inhibitors because those drugs shut down all estrogen in the body. But even in those patients, through the National Comprehensive Cancer Network, where I help to write guidelines for oncologists nationally, we recommend certain types of hormones, certain formulations of estrogen. So
in the vagina,
in the
vaginal,
vagina.
right.
So vaginal estrogen can be used for breast cancer patients. I want to clarify that for
I know. I
for
think that's
people.
a huge misconception. So I'm super
And
happy.
then we will always lean very heavily into lifestyle and integrative things that can be done. Happens to be evidence for things like CBT for hot flashes and for sleep. That may help out with mild symptoms. Dietary things, if someone is obese and they lose weight, that may help out with hot flashes. There are prescription alternatives. There are a number of drugs that can be used, low doses of antidepressants, and older studies with antihypertensive and overactive bladder medicine. All of those drugs, what they have in common is they cross the blood-brain barrier. And we used to say we don't know what causes hot flashes, but it's something, there's some temperature regulation zone in the brain. Well, a new drug hit the market in 2023. It's gotten a fair amount of press. It's called Veozah. And that is the first drug that targets the area within the hypothalamus in the brain, which is where hot flashes occur. It targets what's called these candid neurons. And that's the first drug. There's others in the pipeline. I think we're about to get approval for another one. And that just created another tool in the toolbox so that breast cancer patients and other cancer patients, like high grade uterine cancer patients who also are typically denied these therapies, that they have other options for what they can use. So the biggest thing I tell people is no need to suffer. When you talked about brain fog, a lot of the reason people may be having brain fog is they're not sleeping, they're having the hot flashes at night, they're fatigued. There's evidence if you're tired, you don't make as healthy food choices, you're not exercising as much. So we really do a deep dive into sleep. A lot of supplements people can use for sleep. Magnesium glycinate, lavender helps with sleep-related anxiety. There's studies with ashwagandha. There's a supplement called Cortisol Manager that has ashwagandha and L-theanine, thought to be helpful for people who have middle of the night wakening.
I took ashwagandha once. I was up.
Oh, you know,
1%. 1%. That was me.
Yeah, it
It's the
doesn't help for
opposite.
everyone. Then we also know the risk of sleep apnea goes up after menopause. So we send our patients for sleep studies sometimes. So a lot of people are getting up at night because they have to pee. They may have urinary urgency. Well, this interesting drug called oxybutynin, used for overactive bladder. So it helps out with those symptoms, and it also helps out with hot flashes. So we individualize depending on what other symptoms someone has. Gabapentin, a drug that causes sedation.
I love gabapentin.
Me too.
Yeah.
I love gabapentin.
So if you're having your hot flashes at night, we may give you a little low dose gabapentin. So
Yeah.
we individualize a lot depending on what
And can
someone's
you
telling
use
us.
those medications with hormones too? Do they, or is it just overkill? Because she got mad at me one day because I had like 5 estrogen patches on. She's like, no.
She thought the more patches she puts on.
So again, it depends on the symptom. In general, we try to do one thing at a time, because if you try multiple things at once, you don't know what's doing what. But yes, we sometimes will layer on other therapies.
Any estrogen formulations for vaginal dryness that are contraindicated in women on tamoxifen?
So there's more of a concern for breast cancer survivors on aromatase inhibitors because
And tell us what that is.
yeah. So when someone has hormone sensitive breast cancer, they are treated with these hormonal drugs to modify the tumor environment. Tamoxifen has both estrogenic and anti-estrogenic effects, and how it acts depends on the target tissue in the body and the hormonal environment. So it acts differently before menopause and after menopause. And so tamoxifen sometimes causes vaginal dryness, but you tend to see it a lot more with women on aromatase inhibitors. So aromatase inhibitors are a totally different class of drugs. So most estrogen in women's bodies comes from the ovaries. That's estradiol, which is the hormone that they test if they're sending you to the lab to measure your hormone levels. Turns out there are weak forms of estrogen made in other cells in our body. Fat, muscle, brain, breast, all over the place. by what's called aromatase. So aromatase is an enzyme, and enzymes convert one substance to another substance. And aromatase takes male hormones that all women have. We have low levels of male hormones floating around in our bloodstream, and aromatase converts them into weak estrogens. And what aromatase inhibitors do is they shut that reaction down, and they shut down all peripheral production of estrogen in the body. So the side effects of those drugs are awful because our body likes
Right.
estrogen, particularly our bones and joints. You get lots of joint pain,
Yeah.
negative effects on bone density, higher risk of fractures. And then the vagina, the vulva, the bladder, all very estrogen sensitive. You can see people who say, it hurts so much that I'm sitting in my vagina feels like sandpaper, or I pee and I wipe myself and I tear the skin. Like, this is a huge problem. So with the aromatase inhibitors, because those drugs work by shutting down all estrogen, people have wondered, can you give vaginal estrogen? And that's the form where it's a little bit more controversial, but we have studies looking at certain formulations. The ring and the suppository formulations of estrogen have been studied in breast cancer survivors on aromatase inhibitors, and the hormones are thought to stay locally without absorption into the bloodstream. So those are the ones that, even through the National Comprehensive Cancer Network, the NCCN, we will say that when people have failed over-the-counter things, so with breast cancer survivors, it's recommended to try moisturizers and lubes and oils and all these things first. But if they fail, that it's reasonable to try some of those options.
So like the E-string
exactly.
or the Vagifem.
Vagifem.
What about estrase, which is a very
So,
common one?
Yeah. So the creams tend to be the cheapest and the easiest to use. They're more messy. There is some concerns that when you put a bunch of cream in the vagina, that the surface area of the vagina is greater, and that could potentially lead to absorption in the bloodstream, which you don't want to happen. That's more theoretical. There haven't been any studies, like I mentioned before, that have shown the use
That's
of
the problem,
any
right?
form of vaginal estrogen.
Yeah.
We're half the
impacts survival.
population.
Exactly.
So
and we're all going to go through menopause.
we tend to avoid the cream formulations in the usual way. How people can use cream, if someone has pain along the opening or they tears in the skin, you can rub that into the opening. That's totally fine.
But what do you guys think about estrogen on your face?
Oh,
I ordered some from Midi Health, just so you know.
I love it.
So tell me about that, because I have a lot of friends that are taking their estrogen, vagina estrogen
Yeah.
cream and putting it it's estrogen, right? On your vagina?
It's a type of.
Yeah. They're putting it on their face. So are there studies that show that it actually helps with your skin?
There are really good studies that show it helps.
Really?
I mean, it does the same thing, right? It makes the skin, the epidermis, thicker and more moist.
I will clarify, there's a difference between estriol and estradiol.
So explain that, because
So-
all of you that I know that are putting your estrogen cream on your face, listen to this.
Okay. So the creams that we use for the vagina and the rings that we use for the vagina and the suppositories are all estradiol. That's the same estrogen that our ovaries produces. That is a stronger estrogen than estriol. Estriol is a weak form of estrogen. And there are a number of studies, particularly in the dermatology literature, that have shown estriol is good, like Joanna said, for the epidermis. The theory is it improves blood flow, makes the tissue healthier, improves collagen production, and so it can work particularly for fine wrinkling. So what you got from Midi is estriol and not estradiol. There are women who are taking their vaginal cream and putting that on their face, but that's not what
Just
we're
like they
recommending.
do, they mix their birth control pills. And I mean,
Put it on
But
their-
if what you just said is that the estriol is weaker, then why wouldn't you
Exactly.
put the stronger one on if you really wanted to get into your wrinkles?
So that's a great question. If you can give a weaker form that's going to be just as effective, in general, you try to give the lowest effective dose that treats what you want.
Dr. Goldman, there's so much confusion around when to start hormones and when to end them and how long you can be on them. Can you be on them forever? When is the best time for it to be geoprotective?
Yeah, that's a great question. And some of what we know actually dates back to that large women's health initiative, because when they looked at the women in that study, they found different results depending on the age of the patient. And there have been other studies since the large women's health initiative that have also shown similar things. So what they found is if women start hormones within 10 years of their last menstrual period, or typically under the age of 60, that the benefits tend to outweigh the risks. And specifically, the benefits are decreasing the risk of heart disease. We know it protects against bone loss and potentially protecting against cognitive loss. Now, we know a little less about cognition than we do about the heart. The theory is when you give someone estrogen, it changes the coronary vessels in a way that makes them less sticky, and platelets and all the factors that lead to plaques don't form. So if you start hormones early, you prevent plaques from forming in your coronary vessels. But if you wait and you start someone on hormones after they've been menopausal for 10 years, they probably already have plaques in the vessels. And so estrogen at that time doesn't protect against heart disease. So there's what's called the timing hypothesis. And the timing hypothesis says that the benefits of hormones tend to outweigh the risks if you start people within that 10-year window.
So that 10-year window, can that include perimenopause? If you still have your period, could you have some benefit from hormones?
Exactly. So typically people thought, well, don't give hormones in the perimenopause. And one of the things to realize is the dose of hormones in HRT is lower than what's in a contraceptive. So in the perimenopause, if someone needs contraception, they shouldn't be on HRT. The other thing is HRT doesn't control abnormal bleeding. And a lot of people in the perimenopause they start having changes in their period and abnormal bleeding sometimes. And so HRT isn't going to control that. So again, you need to individualize. But when you're talking about the cardiovascular benefits, that's really talking about it from the last menstrual period. What has changed too, though, is do you need to stop hormones? And it used to be that people would say, well, use the lowest dose possible, stop after 5 years because we're worried about breast cancer, and certainly stop after age 60 because the risks outweigh the benefits at that age. And even the Menopause Society, the leading organization in the US, changed their recommendations in 2017, reaffirmed it in their last guidelines were in 2022, and basically said, use the appropriate dose of hormones for the appropriate stage of menopause, and there is absolutely no reason to stop based on age alone. That doesn't mean you don't need to assess someone to make sure they haven't developed health reasons not to take hormones. They had a stroke, something like that. But if someone is healthy, there is no reason to stop based on age alone. Okay, the other question we get a lot is, what about people who are past the 10-year window who are coming in saying, I've been suffering for 15 years and everyone's told me I can never take hormones. Can I take hormones now? I'm 65 years old. The timing hypothesis is mainly based on cardiovascular benefit, that we know if you start hormones early, you get cardiovascular benefits, but if you start hormones late, you don't get cardiovascular benefits. I will add, despite the cardiovascular benefits, no organization in the US say women should be taking hormones to prevent heart disease. They still say, take them to treat symptoms. And oh, by the way, if you're at the appropriate time in life, you'll get cardiovascular benefit. If you have someone who's beyond that 10-year window, but you knew they didn't have cardiovascular disease, atherosclerosis, hormones could be safe. So there's certain ways that you can calculate out someone's cardiovascular risk by putting into these formulas someone's cholesterol, their lipid profile, their blood sugars, their blood pressure. But nowadays, we also have a test called a CT calcium score. Now, it's not covered by insurance, unfortunately. It's relatively inexpensive. It's usually about $100 to $200. But that can allow you to directly see if you have plaque in your vessels. And if it's low, that means you don't have evidence of coronary artery disease. And we will do risk-benefit discussions and shared decision-making. And there are people that are beyond the 10-year window that if they are suffering and we've shown that they don't have evidence of coronary artery disease, that we're willing to give them hormones.
I love the fact that we're talking about coronary artery disease. I personally, in my practice, send everyone to a cardiologist when at 45. I usually get a baseline coronary calcium scan unless they have family history of heart disease. And, I look at their ApoB, I look at their lipoprotein little a, I look at their ApoE4. And for patients who are at a very high risk of, for example, myself, I carry the lipoprotein little a and the ApoE4. So someone like me is at a higher risk of making plaques. So let's say I have a patient like me, I usually make sure their coronary calcium scan is fine. If they don't have a plaque, I mean, obviously hormone replacements are amazing, but even if they have plaques anywhere in their carotids or their coronary arteries, as long as you treat them and the plaque is stable and it's not advancing, you can still prescribe estrogen.
So
So I just want to make sure we
yes.
just, these patients need to see a cardiologist, need to get worked up. If they need to be on statins, on Repatha, on these lipid lowering meds, once you stabilize them, you can absolutely give them hormone replacement.
And I will say one of the other things we do at Midi is we do lipid management. I had mentioned that I feel like I'm a more holistic doc. We will talk to people. Here's the ways you can calculate out someone's risk for cardiovascular disease, doing these ASCVD scores. And there's another one called the MESA. And generally, that's looking at people's 5 and 10-year risk. But we're seeing people in their 40s and younger sometimes, and they want to talk about their 20 and 30-year risks. And in the longevity space, they're talking about trying to get people's LDL, the bad cholesterol, really low, like 70 or less than 70. So we'll talk about emerging literature with our patients, and we sometimes will prescribe statins to really get them down into these low range. And they've been shown if you get a LDL less than 50, you actually can reverse plaque. We're really trying to individualize, meet people where they're at, trying to understand what are their goals and helping alleviate symptoms and also improve their overall life.
So I just want to make sure that I'm totally clear on what you said. It's absolutely okay to take hormones if you're still having your period, but you're suffering from perimenopausal symptoms.
Exactly. But it's not going to provide contraception, and
Right.
it won't control your irregular
So I want
bleeding.
to add something here for my patients, because it's common as you get closer to menopause, your periods become irregular, but you're also having hot flashes, night sweats, vaginal dryness, brain fog, and you need hormones. One thing I do in my practice that works really, really well, and I don't know if you guys offer that, I actually recommend, especially, women, especially when you have many children, you develop adenomyosis when the walls of the uterus become more glandular, your periods in your 40s become heavier, clottier. But for patients with heavy, clotty periods, they need to have a biopsy to make sure there are no abnormal cells in the uterus. But if you're sure that your patient's healthy and these are premenopausal bleeding or they have heavy periods, one thing I do for my patients, actually put a progesterone IUD in the uterus, and I significantly reduce the amount of the bleed that they experience every month. I cover for contraception, and then I give them estrogen patches.
I knew you were going to say that, and we do that all the time.
Isn't it?
So I think
Yes,
it's great. Now,
best.
the only thing at Midi is we are completely telehealth.
Right.
So
You recommend.
we have to, if someone's going to get an IUD, we have to refer them to their GYN. So there are times that we may prescribe birth control,
Right.
but we know that HRT doses tend to do a better job of treating all of those
Symptoms.
perimenopausal symptoms. So I think that's a great option. I love doing that. And certainly in my practice at UCSF, I do that a lot.
Estrogen patch versus, let's say, estrogen gels. As we get older, our skin gets thinner, we lose collagen. It gets, it rubs on your shirt, on your, on your clothing. Do you prefer patches or do you prefer
Yeah.
the
So,
topical gels?
We tend to use patches first line because
Me
it
too.
tends to be covered by insurers. And oftentimes for the gels, insurers want to see that you failed a patch before they'll cover it. So we're trying to always do drugs that are affordable for our patients. I also think that we have the vast majority of studies that are looking at non-oral forms have looked at it with transdermal. So we tend to know the most about that. But individualized, 10% of women have skin sensitivities and they may not do well with a patch. And certainly I give them gels.
Well, I love it. And that's why,
We're on the
for
same
example,
page.
yesterday I had a 43-year-old. She's like, but I have all these symptoms, but I get my periods once a month. They're so heavy. I'm like, great. We'll put a Mirena IUD. I'm going to give you the estrogen patch. I'm going to give you some testosterone, which we need to talk about. And really, it's life-changing for these patients. Otherwise, if you want to do the estrogen patch with the, let's say, micronized progesterone at night, then you're chasing after these irregular, heavy periods, and it's really uncomfortable for these patients. So for me, I think the IUD is a great option. I just wanted to add that.
So we cannot end this discussion without talking about testosterone.
Yeah.
Once again, I've seen a lot of my friends who said it's been life-changing for their sexual health with their husbands. And so I want to talk about why that is. And number two, I've also seen a lot of people that start to get a beard. I mean, and I know from now that I'm Dr. Haney on this, but it's too much testosterone. So how do you decide how much to use? What is it about the testosterone that helps, get your libido back?
Okay. So let's talk about, should testosterone be given with HRT? Because that's a big question that a lot of people are asking. And when you look at the evidence for testosterone in women, the best evidence is for improving low libido in postmenopausal women. In premenopausal women, we actually have a couple FDA-approved drugs for low libido. Flibanserin, the trade name is Addy. Bremelanotide, the trade name is Vyleesi. The best evidence for testosterone is improving sexual functioning in postmenopausal women.
Wait, that is incredible. You don't understand that I have so many friends that are premenopausal that are taking testosterone for that reason. I mean, I've never even heard of these medicines.
So they can take testosterone, but the other drugs are FDA approved and may be covered by their insurance.
But they have to take, it's a pill.
It's
form.
a pill, yeah.
So
And one's a shot.
Okay.
So this
Take it every day.
every drug has its own side effects,
like
and
taking a
some people
pill.
don't necessarily want to take a pill every day for something they don't do every day.
So testosterone will work in perimenopausal
yes,
women. Okay.
Yes. So testosterone, we know it improves libido. There is emerging evidence about it for other things: muscle mass, bone health, metabolic health. We have much better evidence for testosterone in men when it comes to muscle mass and bone health. It's more emerging evidence in women. We will offer it to women certainly for low libido, and even for these other reasons, if they understand we don't have good data to support it, it's still emerging evidence. The problem with testosterone is it is not FDA approved for women. The reason for that is they actually had patches that showed them to be beneficial for improving libido. They went before the FDA, but it came on the heels of the WHI. And the FDA said, we're not approving anything hormonal till you give us more safety data with regards to the breast. And to this day, it's never been FDA approved. And it's a controlled substance. So to prescribe it, there's a lot of hoops that you have to go through in prescribing it for women. And it's not covered by insurance, and it's expensive. So I like to put all of that out there. That doesn't mean that there isn't a benefit for women in using it. There are very clear protocols as to how to use it. There are national organizations that give good information. ISWISH, the International Society for the Study of Women's Sexual Health, they have very good information on how to prescribe. So there's certain hormone testing you check beforehand. We give certain milligram amounts, usually somewhere between 1 and 5 milligrams a day, and then you check people's testosterone, their free and their total levels, to make sure they're maintained in a certain value. So when you were mentioning about getting male hormone side effects, you both ask people about that and you make sure that their levels are maintained in these values.
I think one of the experience I personally have are with pellets. When these patients come, the ones complaining of extreme sudden hair loss, acne, facial hair, those are usually patients with pellets. The testosterone creams we give, I usually give 5 milligrams. I don't think less than that, you know.
It probably doesn't do as much. We start a little lower. But so because it's not FDA approved for women, the only ways you can give it are 1/10 of a male hormone dose. But the problem with that is the way it's packaged. They would have to break open a package to be able to be in compliance with what they say, because it's a controlled substance where you can only give 3 months at a time. And so that doesn't work for most people, at least the most common form of the male hormone prescription for testosterone. Most people use a compounded formulation. When you're using compounded formulations, you need to make sure that the compounding pharmacy does this third-party testing to ensure that there's purity and efficacy of the drug they say.
How
So
do you
there's
know if they're
issues-
doing that?
So you can talk to the compounding pharmacy and say, tell us about your quality and efficacy and purity of your drugs. Do you do third-party testing? So that's one thing. People do use these other ways, pellets and troches and things like that. We don't, through Midi, recommend the pellets. The problem is once you put them in, you can't take it out. And so absorption is much more variable. You can much more easily control the dosing of it when you use it in these cream formulations. So we tend not to prescribe compounded hormone therapies. There's a lot of issues around that. We use standard bioidentical formulations that are covered by commercial insurers, but we do prescribe compounded testosterone cream for patients.
Before you give testosterone, do you test the testosterone in the blood? Because I've been told that estrogen is really hard to test because it could be different times of your ovulation and different times of the month. So testosterone is
before menopause.
Yeah.
before
Yeah.
menopause.
We mainly test to make sure that people's values are in a certain range, but we don't treat based on values. We treat based on symptoms.
She doesn't either. She says
We-
that all the time. I treat based on symptoms.
But
Yeah.
then I get patients on pellets and their testosterone is in the
It's
400
really
range.
high. That's the
And
problem.
I have a heart attack when I see it, and their doctor is saying, "Oh, you're not feeling well. You're anxious. You need more testosterone." I'm like, "No, you don't."
Yeah. That's
And
the problem
sometimes
with some of those formulations,
with these
right?
pellets, and you
Yeah.
can't take them out, and sometimes you have to wait months for those levels to come back to a normal range, and then I switch them to the topical
Yeah,
testosterone.
We do
cream.
exactly the
Yeah.
same that you're doing.
I'm so proud of you guys for everything you do. Lucky your patients, who come on your platform and who have
Thank you.
access to someone like
It
you.
really is. It's
really,
incredible.
I'm really proud of you.
Thank
And then
you.
before I let you go, I just want to know what you think the future is for menopause care.
Yeah, it's a great question. Where I hope we go is right now, we're still in the phase of getting people to move past the WHI. We need to train people who are training in medicine to understand what are the risks and benefits of hormones? Who should we be offering them? How do we counsel people? Once we get past that, I want to see us get to personalized hormone therapy. For example, if you have irregular bleeding, the bioidentical progesterone that we use for HRT doesn't control that. The old synthetic progestin that they used in the WHI is really good for controlling irregular bleeding. And we know if you're at higher risk for blood clots, you don't want to be using an oral estrogen. You want to use either a transdermal or a spray. So what I'm hoping we get to is we move past that hormones are awful, they cause breast cancer, no one should be on them, to nope, let's individualize for you, and hormones are appropriate for the vast majority of healthy women when they reach menopause. And then let's figure out which hormones should you be on. What type of estrogen, what type of progesterone, should you be on testosterone, and how should we be giving it?
Well, I hope a lot of women are listening to this and, maybe they'll join Midi Health because they just love the research that you're providing. Maybe there's women that listening that don't really have the kind of care that they need. This has been so informative. I've learned so much. Honestly, thank you so much for what you're both doing for women. And I just really appreciate. And as female founders over here, you are such an inspiration to us. Will you just tell everybody how they can find you?
Yeah, so just go to joinmidi.com. And we're in all 50 states. We have national insurance coverage, so we take most PPOs in the country. And if we don't have yours yet, it should come soon.
That's why I'm glad there's a place for all women
Right.
to visit and get the care they need. So thank you for
and
that.
if you're listening, women are half the population. We all go through menopause. We need some research.
Yes,
Yeah,
exactly.
exactly.
Yeah, thank you guys.
Thank you
Thank
for
you
having
again.
us.
Thanks so much for joining us today on SheMD.
If you want to own your own health, a good place to start is by following us on social media at SheMD Podcast and by subscribing to our show on YouTube or wherever you get your podcasts.
For takeaways from today's episode, visit our website, shemdpodcast.com. We'll see you next time on SheMD. This podcast is for educational and entertainment purposes only. It is not intended as a substitute for a physician's medical advice. You should regularly consult your medical provider in matters relating to your own health. Even though we share our honest beliefs on SheMD, some of the products and services we discuss may involve sponsorships or paid advertising.